Welcome to the Investing Podcast presented by Tusk Media. This is Outsider Trading, an audio and video deep dive into the people, places, and things that we find most interesting in the market.
Because if you look at the length of stays too, it's not like, so we talked about ordering the nth test, which is maybe happening at the margin, but doesn't it really explain the dramatic change in costs. Same with length of stays, because there's this big trend toward readmittance. So here's how it works. If you are a hospital and you take someone in for a cold, the flu, what have you, if you discharge them from the hospital and then readmit them within the space of the month, Medicare doesn't pay you. They say, well, you didn't do what you were saying you're going to do, so we're not going to pay you. We're certainly not going to pay you twice. And so what I think the perception is that, hey, hospitals are holding on to these patients longer, so they just have to so they can make sure that, you know, the patient isn't succumbing to the same disease and the patient is purely fine. Mm-hmm. But do the numbers bear that out? No. For example, after a normal delivery, the mother stays in the hospital for 2 days, even. For the rest of the developed countries, it's 2.8 days. Okay, we talk about acute heart attack or myocardial infarction, which is the term you'll hear doctors say. 5.4 days is the average hospital stay versus an average of 6.1. So we're not staying in the hospital longer than other people. Discharges per 1,000, and our hospital visits are less. We're visiting the hospital 125 times per 1,000 people versus an average of 150 times. We're visiting physicians less. We're visiting a physician 4 times a year versus 6.5 times for other people. So contrary to popular belief, our access is actually less, I would argue, than the rest of the world. And yet we're paying more. That does not make sense. We're not able to see physicians as quickly. We are visiting the physician less frequently. We're not staying longer, and only at the margin are we having a few more tests than the rest of the developed countries. And again, we're paying almost double.
So with all that said, where do you think we're spending this money at? Sorry if I jumped the gun, if I cut you off there.
Yeah, no. There are a few more myths I kind of wanted. I wanted to tease that out a little bit, but I think we're eliminating quite a lot of options right now. We're certainly eliminating what a lot of people blame the healthcare costs on, because I think, you know, we've talked about the inferior outcomes. We've talked about less access. We've talked about the amount what we pay versus the rest of the world pays. And even if you talk about drugs, people are making this big push to generics. Well, newsflash, generics aren't going to save us. The fact of the matter is we use more generics as a percentage of drugs than any other country surveyed. By far, 80% of our drugs are generics. This is not physicians who are careless about prescribing the expensive branded drugs. They're prescribing generics, but they just cost way much more. And maybe this is what you were getting to. The fact of the matter is 84% of total drug volume is generics versus an average of 58%. You know, we're getting an inferior product at twice the price.
So if it's not mortality rates, access to care, better drugs, or the health of the population in general, then what is it that we are spending this extra money on?
It's ultimately a cost issue, because, I mean, we've eliminated all those other variables. We've eliminated better quality. We've eliminated higher utilization. And so it ultimately comes down to cost. And we have some statistics on this too. And it's not just one area of cost. It's not just drug costs. It's not just labor costs. It's not just administrative. It's kind of all of the above. And at every step of the way, prices in the United States are higher than the rest of the country surveyed. So if you're talking about services, for instance, You can get a CT scan in the United States for $896. You can get the same CT scan in Canada for $97. Less than $100 in Canada. It's a little more in Holland. It's $279. Switzerland is $432. Australia is really expensive. It's $500. Again,
I'd still rather take the weight any day of the week.
Yeah.
If there is one, you know.
Well, I mean, as we talked about, you know,
Right.
the weight's probably less.
Yeah.
Australia, the cost is $500, and the United States is $896 for a CT scan. Coronary bypass is where it gets crazy, though.
Yeah.
$75,000 in the United States.
Who's got that laying around?
Next is Switzerland at $36,000. You can go to Holland and get one for $15,000. I mean, I would go to Holland, have a really nice trip, enjoy the time, spend $40,000 there,
Yeah.
just going on the canals or whatever, and then still be $20,000 better off.
Right. That's crazy.
MRIs are triple the price. I mean, it almost gets silly when you start talking about these numbers. But when you're talking about the fact that we spend double of GDP versus everyone else, you know, that money has to be coming from somewhere, and it's coming from prices like this. And I think we can talk about drugs as well. Mm-hmm. I think you have some stats on the drugs there.
Yeah. So there's a lot of things going on with drugs. I wasn't aware that we didn't use that many generic drugs. Or you said 80% were
84% are generics versus 58% for other countries.
Okay, so I wasn't actually aware that we used so many, and the reason I said that is because, you know, there's government protected monopolies, and what I mean by that is there's a lot of patents that drug manufacturers will put on their new products, and for the most part, these patents are 20 years or so, and then there's also a kind of a way that they would game the system to get longer patents, and they would just tweak little things about the products. So think about like the pill coating. You know, it doesn't really affect the drug at all, but it's a way for them to squeeze out a little bit longer of a life on that patent. And so if you think about that, and then on top of that, the FDA approval time, that adds another 3 or 4 years. And so my first thought right off the bat was that brand name drugs would actually be more prominent than generic. And, you know, it takes, for every 2 generic products to go on the market, there is a 55% price decrease from the original price of that same drug. So then you add another 3 players into that category, and then it drops another 17% off that original price. So all in all, you know, 24 years later and 5 generic products created, now you have 17% of that original price of whatever drug it may be. That really plays a part in how much we're paying for health.
Yeah, no, I think great point about the generic drugs, and the fact of the matter is, the reason we use so many generic drugs, and the reason that's postulated in this article and this report, is the fact that we really don't have any other option. For other countries in the world, think about the UK, think about Germany, Canada, they're negotiating on the branded drugs. So they're bringing those branded drug prices down, which makes the equivalence with generic drugs much closer. So if you're in France, like, I'll buy the branded drug, it's not 10 times the price. But if we look at some of the prices of these branded drugs in the United States, take, for instance, Crestor, cholesterol drug. Undiscounted, it's $216 a month. With the discounts and with whatever the pharmacy benefit manager does or your insurance company, it's $86. The average for the other countries surveyed is $35. So over double. Take the Lantus drug for diabetes, $373 undiscounted, average is $78. Advair, $310 undiscounted, average $64. And where it gets crazy is Humira. For a month's supply of Humira, which is the rheumatoid arthritis drug, you're talking about $3,400 undiscounted, average of $1,400. So almost every single one is at least double, usually more than double the price of the rest of the world.
With that arthritis thing, it kind of seems like we're almost taking advantage of older people in a situation like that. I don't think that's
Oh yeah,
That's messed up.
We're taking advantage of Medicaid, taking advantage of Medicare. We're taking advantage of, and insurance companies don't seem to be effective negotiating partners, because overall retail spending on pharmaceuticals in the United States is $1,026 versus an average among these other developed countries of $541. So again, we're paying at least double for the same to worse drugs. So, I mean, that kind of gets you right to those numbers of paying double on healthcare overall for same or worse service. Another thing is, doctors are paid far more than anywhere else of these countries surveyed. So for a little bit of a baseline, Americans are richer than other countries. Mm-hmm. Even though these other rich countries, Japan, Germany, etc., Americans are doing better. We earn on average about $60,000 a year. The average for other countries is about $49,000. So you're talking about 22% better off in dollar terms for the average person.
All right, and is this before or after taxes? Is my first thought.
This is before tax.
Okay.
So you're talking about 22% better off.
So it's even more extreme when you add the taxes, just because you think about what they pay for universal health care, or I guess they probably have programs to help send their students to school, right? Things like that. So it's probably even more extreme than that.
So we're 22% better off there. Nurses, on average in the United States, make $74,000 a year. Average for other rich countries is $52,000. So that's 43% better. A generalist doctor, kind of your family medicine doctor, 63% better off. And specialists, 73% better off. So as you ratchet up the education spectrum, you're starting to pay 40, 50, 60, 70% more in the case of a specialist than in other countries in the world. Part of that is the cost of education. And that kind of enters a whole another ball of wax. There was a study done that says the return on investment in education requires a $20,000 to $24,000 premium in annual salary for the United States versus other rich countries. But even if you include that, you're talking about 48% higher wages for generalists and 62% higher wages for specialists. So they're still doing a lot better than everyone else. So we're paying our service providers more. We're paying more for procedures and tests. We're paying a ton more on drugs. And probably the greatest kicker of them all is administrative costs. 8% of healthcare costs go to administrators. 8%. In other countries, that's 1% to 3%. And we're paying, out of every dollar you spend going to the hospital or seeing a doctor or having a test or buying a drug, out of every dollar, you're spending 7 to 9 cents more just because of administrative costs. And that's padding someone's pocket. And it would be great to have that job because all you have to do is shuffle papers and you kind of you rake that extra premium. But that's, these are the issues that we have in American medical costs and outcomes today. And unfortunately, we're kind of focused on the wrong things. We're focused on access and utilization. That was something that the Affordable Care Act really was trying to drive, that people needed insurance, right? And we actually helped do that pretty well. We took the insured population from about low 80s to about 90%. So you reduce the uninsured population or unprotected population by about half. So that sounds really good, but that doesn't really solve any of the problems about the costs of healthcare in the United States and the outcomes of healthcare in the United States. We try to make it accountable. We try to say, okay, well, we can't have readmittance. But that's not the issue. The issue here is that we're paying people way too much and we're paying way too much on drugs. And the only way that we solve those problems is, and I hate to say this because I definitely fall more on the conservative side of the spectrum, but the only way we solve that in such an opaque system is if you have a really strong person or a really strong entity negotiating prices on a lot of this. Because the fact of the matter is, as a consumer, you're talking about a very inelastic good. You're going to pay any amount it takes to preserve your health because it's so vital and important for you and your livelihood. And you have no buying power in that scenario. You have zero buying power. In any type of negotiation, any type of deal, in any type of transaction, think about buying a house. You need negotiating power in that instance. Otherwise, you're going to overpay on it buying a house. Same thing with medicine. You don't want to be forced to buy a house. You don't want to be forced to buy healthcare without having some power levied in the opposite direction.
Right.
Because otherwise, you're just at the mercy of whatever the people want to charge.
Right. And I think that's what other governments are doing is they actually they have health programs where they are negotiating the prices, and if the companies decide, hey, I'm going to charge an excessive amount for a drug, then that government will say, well, you know what, we're just not going to do business. We're not going to cover that particular drug.
And the fact of the matter is, the United States has more power than any of these other countries. Because if you look at, just go to any, so if you go to any investor relations site for any of these large drug companies, think Pfizer, think Merck, think Novartis, Eli Lilly, and just look at their revenue coming from the United States as a proportion of total revenue. Look at their operating income from the United States as a proportion of total operating income. The United States has all the leverage. If we force them to cut prices by a certain amount, they're going to have to go with us because they simply have no option. This is where their profits are coming. Their shareholders would revolt. So, the U.S. is in a great negotiating power. It's just, are we going to use it or not?
Right.
So, I think that's it for us for now. We'll probably hit on some of these themes in upcoming podcasts, so stay tuned. We're on YouTube. We put out a weekly show called Young Bucks. Check out our podcasts for interviews like I did with Greg Silverman, Cody Willard, Jason Polanski, all on there. And we'll continue to do these series in the weeks going forward. Thank you.
Tusk Media is a subsidiary of Narwhal Capital Management. Ratings and reviews of Tusk Media content are not to be construed as endorsements of opinions, analysis, or services offered by Tusk or its parent company. The opinions and predictions shared here are professional beliefs at the time of publication. We are not under duress from any of the corporate entities mentioned. This is not a solicitation to take any particular action. Although we are investment advisors, this information should not be considered investment, legal, or tax advice. We strive to be as impartial, insightful, and accurate as possible. We base our opinions, analysis, and calculations on information we believe to be reliable, but we cannot guarantee its accuracy. We can, however, guarantee that our opinions will sometimes be flat out wrong due to a variety of factors. Employees and clients of Narwhal Capital Management may or may not hold positions in the securities detailed and may or may not hold these positions in the future. A full list of all securities purchased, sold, or held during the 12 months preceding the date of this publication can be provided upon request. Unless otherwise noted, all data accessed via MarketWatch or the Bloomberg terminal. Past performance does not guarantee future results. A copy of Narwhal's Form ADV is available at the SEC's website, www.advisorinfo.sec.gov, or from Narwhal upon written request.